I thank the Indian Academy of Sciences for kindly extending this invitation. It has been a privilege and an honor. So, I am mainly a clinician who works seeing cancer patients from the perspective of medical oncology, which means treating cancer patients with chemotherapy, targeted therapy, bone marrow transplantations, and all sorts of medications, not surgery or radiation. So when we work with cancer patients, especially in India or low middle income countries, we face a challenge, which is there is a survival gap. The survival gap means that in high income countries, the same patients are surviving at a much higher proportion compared to those we find in Indian setting. So this survival gap, we're trying to see what is that survival gap, what are the factors which affect the survival gap, and whether we can target some other supportive care while we are delivering patient cancer care to the patients so that we can bridge that survival gap. So what is our cancer survival in our country and all over the world for that example? So when we talk about long-term cancer survival, so no one really can say that what is a long-term survival for cancer, because cancer patients after their diagnosis can die from various causes which can be cancer related and may not be cancer related. But in general, the long term, when we generally study patient or patient population, we say that 5-year survival, a person who is surviving at least 5 years after their cancer diagnosis, they have achieved something called as a long-term survival. Even if they may die at a later point of time due to some other reasons and even for cancer coming back, but more and less that chance comes down after 5 years. So where are we currently in long-term survival of cancer? So if we see, so I am interested both in pediatric and medical and the adult medical oncology, but cancer survival in children has been a success story, and that is what excites me a lot. So when in 1960s, when children used to be diagnosed with cancer, most of those malignancies were uniformly fatal, also for adults. But the children in the last 3 to 4 decades, their 5-year survival has significantly increased. And in high income countries, this old data, that is 2012, it currently is at 85%, which means 100 children who was diagnosed with cancer in high income countries today, 85% remain alive at the end of 5 years, which is a remarkable achievement. But what is that in case of adults? So this is also slightly old data, and it is a very big variable compared to the type of cancer. We know that germ cell tumor, which is the testicular tumor, it is wonderful, it is highly chemosensitive, and in today's age, in today's date, if we find a patient with a testicular cancer, more or less, they are going to survive. On the other hand, still pancreatic cancer, lung cancer, they continue to be one of the worst type of malignancies, and the survival continues to remain poor. But mind you, this is the old data, this is up to 2007. If we find this all cancers, that was reaching somewhere around 45 to 50%. And the latest data which has been come up from the SEER database of United States, they say that in today's date, even with all the adult malignancies taken together, of 100 adults diagnosed with cancer, around 60% will remain long-term survivor, which means we have also achieved a very big level of improvement even in adult malignancies, considering that adult malignancies are very difficult to treat, they're not chemosensitive enough compared to pediatric malignancies. So this is currently around 85% in children and 60% in adults. But let us come where we are in India. The same thing, same malignancy, same type of biology. In India, the survival is 55% compared to 85%. In adult cancer, it is 30% compared to 60%. So there is a 30% gap uniformly, both for children and adult. So there are multiple reasons, and I am not talking about the social reasons here. I am not talking about the healthcare system, systemic gaps. There are financial reasons, people not coming to doctors on time, cancers diagnosed at a advanced stage. But we have all the molecules. We have all the most of the available treatments which are available in the Western countries and here, but still there is 30% gap, and a part of it is not explained. Why it is all cannot be explained by social reasons and all cannot be explained by systemic reason. So there is a role of supportive care in this gap, and what is supportive care and how to improve it is one of the areas which I am interested in. So if we see the cancer treatment, these are all sorts of treatment which we do for cancer, but the supportive care does not include any of those. They are not directly cancer related, but they improve outcome and prevent toxicities. So what are those? So you can give some chemosensitizing agents. You can sometimes give some agents which improve their appetite, improve their nutrition. You can give some preventive vaccines. You can give some sort of prophylactic antibiotics. You can give some sort of treatment which can prevent chemotherapy toxicity, so that actually you can deliver chemotherapy in a proper intensity and on a timely manner. So all of them are not directly cancer directed, but they help in delivering the cancer therapy in a much more proper way. They are applicable broadly. Most of these therapies are not specific for each and every cancer. They can be delivered to a broad variety of cancer. So targeting nutrition, it is well known that cancer treatment is known to it improves outcome. But it is known, but people really don't know how to target nutrition. It is known that a poor nutrition at the start of treatment and during treatment is bad, but it is not very well known that how better we can target nutrition. It is well known and very easy for a doctor to say to a very debilitated cancer patient that you should eat more protein, but the patient is fully cachexic, they have a very poor appetite, so they are really not heeding to those advices. So we studied a lot of nutrition in pediatric oncology. We started macronutritional and micronutritional parameters at baseline and follow up and see how it affects the outcome. We did a cohort of patients of micronutrient profile in a cohort of patients from 2012 to 2016 and then followed till 2020 and see how their baseline micronutrient profile affects the outcome. And along with micronutrient, we then also created a nutritional database from 2016 to 2021 where micronutritional parameters were measured and followed up serially, and the patients were followed up till 2023 to see how their outcome was. So this was the first thing from the micronutrient deficiency. What we did is at the baseline, even before starting any sort of treatment, we analyzed their micronutrient parameters, vitamin B12, folate, zinc, selenium, copper, and iron, and tried to see that which are those patients who are deficient in those, which are those patients, and are those serum levels really affect their long-term outcome or not. And we actually analyzed 535 children, included over 4 years, followed them up for more than 5 years. We found that vitamin B12, zinc, iron were the most common deficiencies of children who were diagnosed with cancer at baseline. And at least 81% of patients were deficient in any micronutrient and 14.4% were deficient in multiple micronutrients. Now people may now say that, okay, micronutrient deficiency is there, so why don't we supplement with micronutrients? But there has always been some sort of conflict that whether to do micronutrient supplementation or not. A lot of those micronutrients have antioxidant properties, and whenever we give chemotherapy, they need reactive oxygen species to cause the DNA damage and actually kill the cancer cells. And giving micronutrient supplementation without really understanding and actually getting the reactive oxygen species down may be detrimental. We further analyzed their long-term survival, the event-free survival of the cohort and the overall survival of the cohort, and saw that it was selenium which was, even though it was deficient in less number of patients, but selenium deficiency significantly predicted poor survival outcome in both the overall cohort and especially in hematological malignancies. So in children, hematological malignancies, leukemia and lymphoma are common malignancies. And it was predominantly the acute lymphoblastic leukemia subgroup where selenium deficiency was found to be a significantly poor survival outcome, which shows that children who are diagnosed with acute lymphoblastic leukemia, especially that subgroup, and who are deficient in selenium at baseline, even if we are giving the proper treatment, they are likely to even relapse more quickly, and they are also likely to die more quickly. On the other hand, when we analyzed solid malignancies in children, which is comparatively less common in children compared to adults, but in solid malignancy, we found that it was zinc, which was more predictor of the poor survival outcome. Here we found that zinc, rather than affecting the survival along with event-free survival, but it was more of toxic related deaths. The zinc is a mucosal barrier. It helps in the maintenance of the mucosal barrier, and we found that the children who are deficient in zinc, they're more likely to develop a lot of mucositis and a lot of toxicities due to chemotherapy, and they finally resulted into the chemotherapy could not be delivered in a proper manner, and because of the suboptimal delivery of chemotherapy, they are more likely to have a toxic related death, and then also more likely to have relapse. Then further we tried to develop a prospective nutritional database of children. Around 2000 children were recruited, and they have been followed up from baseline and regularly at 3 monthly interval while undergoing cancer treatment. We measured their height, weight, mid-upper arm circumference. The height, weight and mid-upper arm circumference, everything measures the separate things. The height in children is a marker of chronic undernutrition. We measure a parameter called as height for age, and a person who has stunted for age is a marker that they has been chronically undernourished for a long period of time, even much before the diagnosis of their cancer. On the other hand, weight for height, which is a parameter which is a marker of acute malnutrition, where there has been a sudden decrease in weight, even if they have actually achieved a proper height, that may be affected by their diagnosis of cancer and poor appetite during the malignancy. And mid-upper arm circumference is just a surrogate marker of their muscle mass. So we measured all these parameters, and when we measured these parameters longitudinally, and we categorized them that gradually when they have been followed for more than 5 to even up to 7 years, a few patients, there have been 3 groups of patients. So patients who gained more than 5% of their weight after starting their cancer treatment. There have been patients who continues to remain plus or minus 5% of their weight, and there have been few patients who has a loss of 5% of their weight. We consistently found both in event-free and overall survival that this is the group where even with the start of cancer treatment, the patient unable to gain weight. In any normal children, they gain weight continuously. During cancer treatment, when the cancer treatment starts taking effect, the cancer cachexia goes down, their appetite improves, and they should actually gain weight much more rapidly. But there will be a subset of patients who will continue to lose weight of more than 5% is a specific cutoff which we chose. But the idea is that children who are unable to gain weight, even undergoing cancer treatment, they will consistently have a poor survival outcome. And the baseline we found that it is the chronic undernutrition. Those who have a height for age less than -2 standard deviation at baseline, which is a definition or cutoff which we use for chronic undernutrition, also predicted poor survival outcome. So we have all this thing and we analyzed, okay, yes, we understand the chronic undernutrition is bad, we understand the weight loss is bad, and we also found those things that this is also well known in adults that cancer cachexia, someone who, at the diagnosis of cancer who has a weight loss of more than 10% within the previous 3 months during their cancer diagnosis, they are likely to very much die within 6 months. So those information we already had. So what to do? So we conducted a trial of olanzapine. So olanzapine, as we know, that it is a atypical antipsychotic. It is given to patients with schizophrenia. It acts on dopaminergic receptors, and along with dopaminergic receptors, it also acts on histaminic and serotonergic receptors in the brain. So it is a drug which is used by psychiatrists, but it is an excellent antiemetic. So we kind of repurposed it as medical oncologists. While treating patients with chemotherapy, we used to give them short course of olanzapine, and it is an excellent antiemetic and used to prevent chemotherapy-induced nausea and vomiting. It has been used in adults to see how in adult patients it has been shown that it improves weight and it also improves appetite. And adult patients with cancer cachexia, they develop after giving 3 months of olanzapine, they have a very significant proportion of patients develop weight gain of more than 5%. So we tried to see whether this holds true in children as well. So we did a multi-center phase 3 trial in 3 centers in AIIMS New Delhi, in JIPMER, as well as Adyar Cancer Institute in Chennai, where 130 children with solid organ malignancies were randomized to olanzapine diet versus only diet arm while undergoing cancer treatment. 3 months of olanzapine was given to evaluate whether proportion of children with more than 5% weight gain improves on addition of olanzapine. Surprisingly, we did not find there was any change in the 2 arms. Both the arms, 39% versus 35%, addition of olanzapine did not help in improvement of weight gain in children. This is in contrast to adults, where adult it has been shown benefit and is currently now recommended also as a part of society guidelines for patients with cancer cachexia to prevent weight loss. So we are currently studying, there are various reasons for it, because the type of biology in adult malignancies and the pediatric malignancies are slightly different. The adult malignancies, the pro-inflammatory profile, the cancer cachexia is more dominant, while in children they are very chemosensitive, and there is a lot of malignancies in children where steroids are given commonly, and so steroids perhaps have blunted the effect of olanzapine. So trying to see the plasma biomarkers currently which predicts the weight gain during cancer treatment. So overall, we observed that chronic undernutrition at baseline, micronutrient deficiency and weight loss, these 3 factors adversely affect survival outcome in children with cancer, but interventions to reverse those are currently limited, and that is what we are currently working on. I thank All India Institute of Medical Science, New Delhi, where I worked on all these studies, and currently AIIMS Kalyani, where I am currently working, and I thank you all for your kind attention.
So maybe I'll start with a question. So Shuvadeep, you did not mention that although there was no increase in weight, the proportion of children for whom the weight decreased, that was different, right?
No, that was not different. So we just calculated the proportion of greater than 5% weight gain. So that also remained same, and the person who the weight remained within plus or minus 5% or any weight loss, that also remained same. So the 3 categories were broadly similar in the 2 arms. So yeah, so this is just 2 groups. So who gained weight and who?
No, I'm looking at the figure on the right.
This one, right?
Yes.
Yeah, so this is the decreased in the weight.
So it is 25 versus 33.
Yeah, so that is not significant. There was no statistical
did not come out as significant. Okay. The other question is, why is the trend changing in bladder cancer? So in your first slide, every cancer, the survival actually improved except bladder. Why is that so?
Which ones?
The first slide.
This one?
No, first one. The overall epidemiology.
Yeah. So that is a completely different thing. So initially, that is an epidemiological problem. So initially, when non-invasive bladder cancer was, there is 2 types of bladder cancer, which is muscle-invasive bladder cancer and non-muscle-invasive bladder cancer. So initially, when the epidemiological calculations were being done, the non-invasive bladder cancer were also being included.
So the definition has
changed. Yeah.
Okay.
So
all right.
Yeah, please.
So, Shuvadeep, one quick question. Very nice talk. One quick question with respect to the long-term survival.
Yeah.
You are only looking at these factors that are intrinsic to the individual, but you're not looking at the exact mutations. Is it possible? I'm just loud thinking that those who are not long-term survivors, they have some specific bunch of mutations, while those who are surviving more, you didn't relate them to the mutations. That's one question. And the other simple question is, you showed a graph where for prostate cancer it was completely different compared to the other organs, and why?
Yeah. So coming to the first question, it's actually a wonderful question. So all malignancies, there is some genetic component which predicts their survival. So while analyzing, we have adjusted for the risk groups of the malignancies, and whatever the analysis and the hazard ratios, those are adjusted for the risk groups and the staging. So which are the known confounders of the survival outcome. Coming to this study, whatever, so where is the prostate? I have not.
The prostate is the one which is
Yeah, so I think that is probably when we started using androgen deprivation therapy. So androgen deprivation therapy
Let me try and give you another explanation.
Yeah, please.
What has happened is the way prostate cancer is diagnosed has changed.
Yeah, that is another.
These are all prostate cancers. Now we diagnose them by doing PSA and you pick up. And you know how prostate cancer is, whether it's a cancer is a question. And that's where my question was, why I raised my hand. When we compare 5-year survival in cancers in adults in the West versus in India, the nature of cancers may be very different. Prostate cancer forms about 25% of the cancer in the West, and many other cancers there are being diagnosed by screening, and you would have a lead time bias and those biases. Whereas in India, we are picking up cancers by after symptoms occur, and also they are picked up at a late stage, so that's part of the thing. Secondly, I'm not actually surprised that you found micronutrient differences and that those who lost weight did poorly compared to the very good talk, but the problem is that there is in medicine and there is a bias of reverse causation. Those who have more advanced disease are the ones who are likely to lose weight compared to those, so basically the weight loss and weight gain separates those who have more aggressive disease versus less aggressive disease, and that's part of the reason. So it's a cause rather than the consequence, and therefore treating it may not make a difference.
Yeah. So we actually don't know which one really came before, but in a way we have adjusted for the stage and risk as I explained. So some of the risk factors which affects the weight loss and other things is taken care by that adjustment by the analysis. But this part is known that patients with cancer cachexia, if we target their weight loss by giving supportive and adjunctive therapy, we improve their survival along with the cancer treatment, whatever else we are giving. And so olanzapine, the survival also improved in adults by giving additional olanzapine. There is a new molecule which has come up, which is ponsegromab, which affects GDF15, which is a cachexia causing molecule. So that also has shown that in cancer that it improves the survival. So weight loss, targeting weight loss during cancer treatment is not something that we should ignore. We should also treat it separately.
Yeah, and the micronutrient fortification that you have done, the point of bioavailability and bioaccessibility has to be differentiated. If that is not differentiated, then the confusion will arise. You may give, but in one case it is bioavailable, in the other case it is not bioavailable. In one case it is bioaccessible, the other case is not bioaccessible. So it's very important, just by giving it a dose, we assume that we have made a control experiment. But actually the individual response of bioavailability, bioaccessibility, and also assimilability, bioassimilability has to be differentiated. Otherwise the cohort will be wrong decision or wrong data that shows up. Thank you.
Yeah, so I just wanted to add to the comment. So we have not done any micronutrient supplementation experiment. One of the reason I told that there is some concerns that micronutrient may affect the chemotoxicity. So we have not done that. Another thing we have not done that this micronutrient deficiency, it may be a reflection of the inflammatory state in the body. So in inflammatory state, the micronutrient level goes down, and so their level has to be adjusted based on the blood CRP levels and all those things. So actual level of micronutrient, whether it is deficiency because of their dietary thing or because of increased usage because of their inflammatory state, that part we have not differentiated. So that I kind of answers your question.
Excuse me, sorry.
Yeah,
It
please.
might sound like a little naive, but my question is that, like you said, you gave a certain drug to in adults, it was seen that their appetite was increased and it was helping them in the survival, right? What if, let's say, the person you were giving the drug to, their oncogenes develop a resistance to the drug, and if the person gets cancer second time after getting treated, do you think that if you give the drug again and it has resistance to it, so is there any, and they lose weight more than they would have lost in the first time, so is there something to avoid that or something?
Yeah, so this drug does not act on the cancer cells, right? So it is a kind of an antipsychotic which acts in the brain. Okay, so it is not acting on the cancer cell, it is acting on the appetite regulation pathway of the brain. So there is no question of having resistance, the cancer developing resistance to that drug, right? Yeah. Okay, thank you.